Hi, everyone. On today's podcast, we're going to talk about some important updates we've made to the Evidence-Based Birth signature article on birthing positions. Welcome to the Evidence-Based Birth podcast. My name is Rebecca Decker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. Join me each week as we work together to get evidence-based information into the hands of families and professionals around the world. As a reminder, this information is not medical advice. See evbirth.com/disclaimer for more details. Hi, everyone, and welcome to today's episode of the Evidence-Based Birth podcast. My name is Dr. Rebecca Decker, pronouns she, her, and I'll be your teacher for today's episode. Today, I'm so excited to bring some brand new research about birthing positions during labor. But before I get started with the content, I have an important announcement, and that is this is the last week to register for our free fall webinar on the evidence on Pitocin. We have 2 dates available for the public to watch, Wednesday, October 19 and Sunday, October 23. Registration is open for a few more days, and you can go sign up to attend for free at evbirth.com/webinar. Typically, these webinars are available only to our pro members every month, but this October, we're opening the opportunity up to everyone to attend. If you can't make it to the live date and time, go ahead and sign up anyways because we will send the replay out to everyone who registers. And again, you can sign up at evbirth.com/webinar. So now let's talk about the evidence on birthing positions. Earlier this year, we published our first podcast related to this topic. It was episode 221, and it was part of our series on protecting the perineum. So in that episode, we focused on birthing positions in terms of their effect at preventing tears. And we also talked about other tried and true midwifery practices for preventing perineal tears. Then this summer, I did an updated literature review to see if we needed to update our signature article on birthing positions, and I found quite a few new scientific references on this topic. So today we're going to dive deeper into this new evidence on birthing positions, and I can't wait to share this new research with you. Are you ready? Let's go. So first of all, we have a new introduction to this article. We're trying to rewrite all of our articles, and as we do, make them more friendly to people who are pregnant for the first time and other people who are new to these topics. So I want to read to you our new introduction. Have you ever thought about what position you would like to use to give birth? Most movies and television series depict birthing positions such as back lying or semi-sitting in bed. But many people, if given the choice, instinctively choose a more upright position for birthing their baby, such as hands and knees, squatting, or kneeling. What is the evidence on the different positions that can be used to help push your baby out? And why are the lying or semi-sitting positions so frequently recommended or even required in hospital settings? We explore these topics and more in this Evidence-Based Birth signature article on birthing positions. After the introduction, our article goes into the different definitions that are related to birthing positions. And we define the second stage labor as when the cervix is completely dilated at 10 centimeters, and that second stage ends with the birth of the baby. In research, though, the second stage is sometimes divided into a passive phase, an active pushing phase, and then the actual birth of the baby, which is sometimes called the delivery, when the baby's head, shoulders, and body are emerging. So in our signature article on birthing positions, we are focused on birthing positions anytime during the second stage. And we do not cover things such as coached pushing or immediate pushing versus delayed pushing. But whenever possible in the article itself, when we're looking at birthing positions in the second stage, we try to know if they were looking at birthing positions during the passive phase, the active phase, or the actual birth or delivery of the baby. Upright birthing positions include standing or squatting. Often with those positions, you're supported by a partner or a prop, kneeling upright or being on your hands and knees, and using a birth seat. So in an upright birthing position, such as one of these, gravity can help bring the baby down and out, and there's less risk of compressing your aorta. The aorta is the large blood vessel that carries oxygenated blood from your heart to the rest of your body. So more blood flow through the aorta means a better oxygen supply to the fetus, which leads to a lesser risk of having abnormal fetal heart tones, which means you have a lower risk of having an emergency cesarean. And the research does support that line of thinking. Also, when you're upright, the uterus can contract more strongly and efficiently. The fetus can get in a better position to pass through the pelvis, and research shows that it's less painful than lying on your back. Studies that use MRI machines have shown that compared to back lying, the measurements of the pelvic outlet become wider when you're squatting or kneeling or in your hands and knees position. Also, research has shown that upright birthing positions may increase satisfaction and lead to more positive birth experiences. However, despite these well-known benefits of upright birthing positions, most people who give birth vaginally describe pushing and delivering lying on their backs. And in fact, a recent study by Declercq et al. On people giving birth in California found that up to 95% of people described giving birth either lying on their backs or kind of semi-sitting or leaning back in bed. But in contrast, research from home birth settings, where people are more likely to use their own natural instincts, confirms that when people are free to choose the position of their choice, they do not usually choose to lie on their backs or semi-sitting in bed. There was one study from Europe that looked at nearly 3,000 people who had planned home births and found that 65% gave birth in either an upright or a side-lying position, and it was only a minority of people who gave birth lying on their backs or in a semi-sitting position. A few more terms I want to define for you before we go further are the different terms referring to lying down, lying back, sitting up. Supine means lying on your back. If the head of the bed is elevated, then this might be called semi-sitting. So it's technically still a reclined position when you are kind of sitting in the hospital bed with the head of the bed elevated. So that is technically not an upright position. The lithotomy position is when you're lying on your back in a supine position with your hips and knees flexed, your thighs apart, and your legs are supported either in raised stirrups or by people who are holding your legs in the air. And then side lying is when you're lying on your side. That's also called the lateral position. Another way to classify birthing positions is whether your body weight is on or off the sacrum. The sacrum is a large flat bone at the base of the spine, and the coccyx or tailbone makes up the bottom tip of the sacrum. A computer simulation of the birthing process found that when the coccyx is allowed to move freely, that it can move nearly 16 degrees, which can make more space for the baby's head to come down and out through the pelvis. In contrast, with non-flexible sacrum positions are used, the coccyx can only move about 4 degrees. Researchers have found consistently that positions that take weight off of the sacrum and allow the pelvis to expand can make spontaneous birth, which means birth without the use of surgery, vacuum, or forceps, more likely. So flexible sacrum positions take the weight off the tailbone, and that includes kneeling, standing, hands and knees, side lying, squatting, or using a U-shaped birth seat. While non-flexible sacrum positions put weight on the tailbone, and those include supine or back lying, with or without the head of the bed raised up, semi-sitting in bed, and the lithotomy position. The next section of our article moves on to talking about why do most people give birth on their backs. And I really had fun rewriting this section. I organized it into categories to make it easier to browse. And the categories that I cover include convenience for healthcare workers, it's easier to do non-evidence-based fetal monitoring, how healthcare workers are trained, the use of epidurals, myths about protecting the perineum, system pressures, and the symbolic importance of the hospital bed. So throughout this section, I added new research from countries around the world. I think it's important to point out that birthing positions in this whole topic, this is a universal, it's a global topic, and all around the world, we are struggling with the fact that healthcare workers are sometimes pressuring or requiring people to give birth on their backs. This is not a problem that is unique to the United States. For example, in one study that took place in India, 92% of labor and delivery nurses were aware of upright birthing positions, and 83% believed that women should have a choice of birthing in an upright position. But 100% of nurses said that the lithotomy position was the most common birthing position. Ease and convenience and overcrowding in the labor room were the most common reasons for not allowing patients to use the birthing position of their choice. New research from Tanzania also illustrated how healthcare workers are trained primarily in non-upright birthing positions. And if a physician or a midwife has only been trained in back-lying positions, such as the lithotomy position or semi-sitting, they might feel that they can't handle an unexpected emergency if someone's in an upright position. And this might explain why some doctors and midwives and nurses are so focused on getting patients to lay on their back or assume the lithotomy position for birth, even when the birth has been going smoothly. As one nurse midwife stated during a study interview in Tanzania, quote, "Women are not allowed to choose the birthing position when they are at the hospital. If the woman chooses a position and at last she ends up with a problem, the midwife will be held responsible. Why should the midwife allow the woman to choose the birthing position? It is wrong and not right." End quote. In this same study of nurse midwives, if a mother insisted on pushing or birthing in an upright position, the mother was labeled as, quote, uncooperative, and the midwives would continue to pressure them to get into the lying down position. I added a brand new section in this category all about why are upright positions so rare, and that includes myths about protecting the perineum. So some providers believe that they need to use special techniques during the delivery, such as perineal massage, where they're using their hands to rub and stretch the vagina, or an episiotomy, which is a surgical cut with scissors to widen the vagina, or the modified Röntgen maneuver, which is when you use your hands to press outside the birthing person's rectum and manipulate the baby's head into a tucked chin position. Now, these techniques are more easily performed if the patient is in a lithotomy, semi-sitting, or lying back position, with a healthcare provider sitting at the foot of the bed between their legs. However, research does not support these methods for protecting the perineum, and in fact, the most protective method for preventing tears involves not touching the patient's genitals at all during delivery. Furthermore, episiotomies are extremely harmful and can have negative long-term health impacts. So upright birthing positions have an advantage in that they make it harder for care providers to manipulate your genitals during the birth. So I cover these myths and why the hands-off method is more effective in our EBB podcast series on protecting the perineum. So for the research on that, you can visit EBB podcast episodes 206, which focuses on episiotomy, 210, which focuses on the hands-off method versus hands-on, 218, which discusses perineal massage, and 221 gives even more info about the hands-off method and how upright birthing positions work with that. The other new section in here all about why it's so difficult to birth in an upright position, or why so few people birth in upright positions, is the symbolic importance of the hospital bed. And it was really interesting to write this section. So I learned that hospitals often invest tens of thousands of dollars in specialized birthing beds that can be broken down to support a range of positions, from lithotomy to hands and knees to even squatting. The hospital bed takes a central location and importance in the typical hospital birthing room. It's almost throne-like in its placement, and each bed can cost anywhere between $4,000 and $10,000 US. The hospital bed itself is a potent symbol of the rite of passage of having a technologically driven birth. In her books, anthropologist Robbie Davis Floyd, PhD, writes that, quote, "Rituals transmit their meaning through symbols. A symbol is an object, idea, or action that is loaded with cultural meaning. Instead of being analyzed intellectually, a symbol's message will be felt through the body and the emotions. Routine obstetric procedures are highly symbolic," end quote. When you put on a hospital gown and get into the hospital bed to give birth, this symbol conveys that you are sick and you need the technology and skills of the hospital staff. Then when the hospital bed is combined with the lithotomy position, where you are positioned with your legs up in the air and genitals exposed for everyone to see, with the practitioner standing over you. This can be seen as a symbol for powerlessness for you and status or authority for the practitioner. The significant financial, ritual, and symbolic meaning of hospital beds may help explain why hospital staff are so insistent that deliveries, whether they're upright or lying down, should always take place in bed, and why many hospital staff are resistant to birth outside the bed or even in a tub. In contrast, births that take place at home and in freestanding birth centers provide access to a variety of props, furniture, and tools. And these environments encourage upright birthing with the purpose of facilitating a normal birth and empowering the birthing person. So in the first randomized controlled trial of its kind, it's still going on at the time I'm recording this. Researchers in Germany are studying changes to hospital birthing rooms that encourage upright birthing positions to enhance relaxation and comfort. In their, quote, intervention group, you would have access to a room that includes a bed that is absent or hidden, a mattress and foam mat on the floor, a beanbag or easy chair, a foam element that's shaped like a birthing stool, a snack bar with tables and chairs, posters showing upright positions, a monitor showing natural sounds and music, and a sign on the door automatically requesting privacy. In the control group, the delivery bed has a central place in the room and is accessible from all three sides. A birthing stool, a birth ball, and a length of fabric suspended from the ceiling to use for support while standing or squatting remains available as per usual in Germany. The results from this study, known as the Beat Up trial, have not yet been published, but the researchers plan to examine the effects of these special birthing rooms where the bed is absent or hidden on cesarean rates, episiotomy rates, perineal tear rates, epidural use, newborn health, and feelings of self-determination. And a similar study, known as the Room for Birth trial, is also taking place right now in Sweden. So far I've gone over definitions and info about upright birthing and why most people give birth on their backs. Next, I want to move into the section all about the evidence on giving birth in upright positions, both for people without epidurals and those who are giving birth with epidurals. So most of the research on this topic is separated into those two categories. They're either looking at people who are having an unmedicated birth where there's no epidural, or you're having a medicated birth with an epidural. So let's look first at the new research on giving birth in upright positions without an epidural. So without epidurals, which birthing positions are best supported by the evidence? Well, there was a systematic review and meta-analysis published by Zhang et al. In 2020, where they combined 12 randomized controlled trials with more than 4,300 participants who were randomly assigned to either upright or recumbent birth. Now, they excluded on purpose any studies that used the lithotomy position because of the known harms and increased risks of the lithotomy position. They stated, quote, "These horizontal positions can have serious negative effects on maternal health and are not recommended by many international organizations," end quote. So as a result, this review is a little bit smaller than some previous reviews, which did include the lithotomy position. But overall, this meta-analysis by Zhang et al. In 2020 was really high quality. They followed the latest guidelines for publishing reviews. They were mainly focused on people who are pregnant at term with low-risk pregnancies. You had to be pregnant with a single baby. You had to be in spontaneous labor, so not being induced, and you could not have an epidural to be in the trial. The researchers defined an upright position as walking, standing, leaning, using a birth chair, semi-sitting, squatting, or kneeling. However, none of the studies used semi-sitting as an upright position, so we don't need to worry about that being included as an upright position. Upright birthing positions were used only in the passive phase in 4 studies, only in the active pushing phase in 3 studies, and in the entire second stage in 7 studies. That means including the actual delivery. The reviewers defined recumbent as side-lying, lying down, or lying with the head of the bed raised up. The studies from this review came from all over the world, and they were published anywhere from 1983 to 2017. Unfortunately, the risk of bias was unclear in 8 studies, and the risk of bias was high in 4 studies. Many of the studies had problems with randomization, blinding, and a few studies had problems with people dropping out of the study. So because of that, we have to take this review's findings with caution. Overall, they found that upright birthing positions led to a lower rate of instrumental delivery, meaning you were at lower risk for having forceps or vacuum use. A shorter length of the active pushing phase by about 8 minutes on average, and a much shorter length of the active pushing phase when squatting was used by 16 minutes on average. There was a substantial decrease in the risk of severe perineal trauma, and there were only 2 studies that looked at this out of the 12, but they found a pretty large reduction in the risk of having severe perineal tears. There was, though, a higher risk of second-degree tears, which is considered a more minor type of tear, with the positions of squatting and sitting on a birth seat. There was no difference in blood loss between groups. This is in contrast to earlier reviews that found a higher risk of blood loss in upright groups. And there's no difference in the length of the entire second stage. Now, when it came to episiotomies, the effective birthing positions on episiotomies was unclear because the studies had a wide range of episiotomy rates, which made it impossible to combine the results. For example, some studies had episiotomy rates close to 0% in both groups, while some studies had episiotomy rates of close to 90%, depending on the culture of the practitioners in that area. Now, I mentioned earlier that there was the higher risk of second-degree tears with squatting or using a birth seat, which might be surprising to some people. But this can be explained by the fact that in those particular studies, the higher rate of second-degree tears was exchanged for a lower rate of episiotomies. So other researchers have also found strong evidence that natural tears heal easier and are less traumatic to tissues than episiotomies. So having a higher risk of second-degree tears in exchange for a lower risk of episiotomy is considered a good trade-off. Other outcomes such as pain, satisfaction, or the use of Pitocin to augment labor were not examined in the Zhang meta-analysis. However, there are other individual randomized controlled trials that have found additional benefits with upright birthing positions. For example, in 2017, Moraloglu published a study with 102 people giving birth without epidurals. This took place in Turkey. People were randomly assigned to push and give birth in a standing or squatting position holding onto a bar, or the lithotomy position with the head of the bed raised 45 degrees. The researchers found that those who stood, then squatted down with a bar to push, had shorter second stages of labor by 34 minutes. They also had significantly less pain, were less likely to receive Pitocin to augment labor, and had higher satisfaction with the birth experience, compared with the group that pushed and gave birth while back-lying with the head of the bed raised. Other individual randomized trials, when you look at them alone, have found that in people without epidurals, upright birthing positions lead to significantly lower rates of pain, lower rates of shoulder dystocia or difficulty with birthing the baby's shoulders, lower rates of abnormal fetal heart tones, and lower rates of emergency cesarean. So in general, this paints a picture of a large body of research supporting the benefits of upright positions for birthing people and their babies, and in contrast, showing the potential risks and harms of lying down or the lithotomy position for giving birth. Now, for people with epidurals, which birthing positions are best supported by evidence? Epidurals are common in many countries. For example, most people who give birth in the United States use epidural or spinal analgesia. In this revision of the signature article on birthing positions, I chose to focus on one randomized trial because this one very large randomized trial dominates the one Cochrane review on this subject. So let's talk about the Bumpy's trial on side-lying birthing positions with an epidural versus upright birthing positions with an epidural. The Bumpy's trial, spelled BUMPES, was a very large randomized control trial on birthing positions carried out by a group of researchers in the United Kingdom. This group compared the upright versus side-lying positions in first-time birthing people, all of whom had a low-dose epidural. Between 2010 and 2014, more than 3,200 people were enrolled in this study from 41 centers in the UK. To be included in the study, participants had to be over the age of 16, pregnant with a single head-first baby at 37 weeks or greater, planning to give birth vaginally, and in the second stage of labor with a low-dose epidural. Since participants were not randomized to upright or side-lying positions until the second stage of labor, this research does not apply to positions with epidurals in the first stage of labor before you reach 10 centimeters. It also does not tell us anything about the back-lying, semi-sitting, or lithotomy positions with an epidural. So the upright group was assigned to be moving on foot, standing, sitting, kneeling, or in any other upright position. The non-upright group was assigned to side-lying with the head of the bed raised up 30 degrees. Because everybody in this group was supposed to use the side-lying position, I'm going to call this the side-lying group. About 80% of participants who were assigned to both the upright and side-lying groups were able to move around, meaning that they had true low-dose epidurals. For the most part, people used their assigned pushing positions. And the researchers found that fewer people assigned to upright birthing positions experienced spontaneous vaginal birth compared to people in the side-lying group, 35% versus 41%. So they define a spontaneous vaginal birth as giving birth without the use of surgery, forceps, or vacuum. Now, most people in this study gave birth with either cesarean surgery or with vacuum and forceps. And I was surprised to see such high rates of intervention in this study. The rate of vacuum and forceps assisted births was 51 to 55%. This means more than half of everyone in the study had forceps or vacuum to help deliver their baby. And more than half of the people in the study, 55 to 59%, received an episiotomy, a procedure that is known to increase harms. These numbers in general are very high. In the United States, for example, the overall rate of forceps and vacuum birth is only around 3%. And the episiotomy rate can vary in the United States, but it's usually in the teens percentage points. So we have to keep in mind that for some reason, the practitioners in the study were using extremely high rates of intervention. Now, it's not clear why people in this study who were assigned to give birth in an upright position were less likely to have a spontaneous vaginal birth. Remember, their percentage of spontaneous vaginal birth was 35% compared to 41% in the sideline group. So not a very big difference clinically, but it was statistically different. The researchers did not see a difference between groups in rates of failure to progress or fetal distress leading to vacuum or forceps use. They also did not find a difference in any other health outcomes. It could be that if you have a low-dose epidural that you might have a better chance of giving birth without forceps or vacuum when you're using a side-lying position for the second stage of labor rather than an upright position. However, because these results had such strange forceps and vacuum rates, with more than half of the study participants receiving forceps or vacuum assistance, I really don't think that these results would apply to settings where there's more support for spontaneous vaginal birth, where there's less use of vacuum or forceps. In this article, I also added 2 new studies about how the lithotomy position, lying on your back with stirrups or having your legs raised in the air, is harmful if you have an epidural. In the first study that we included on the lithotomy position with epidurals, researchers randomly assigned nearly 200 people giving birth at a hospital in Spain to a, quote, traditional model of birth or, quote, an alternative model of birth. Those assigned to the traditional model began pushing in the lithotomy position immediately after they reached 10 centimeters, and they also gave birth or delivered in the lithotomy position. While people assigned to the alternative model delayed pushing and gave birth in a specific type of side-lying position. In this alternative model group, they were instructed to change their positions every 20 to 30 minutes after full dilation, and they were also told to begin active pushing efforts only after they started feeling a strong urge to push. This alternative group had hospital staff assisting them into different positions like sitting, kneeling, side-lying, or hands and knees. After 2 hours in the passive phase, if they still did not feel an urge to push, they were asked to start pushing with each contraction. So that was with people if they had an epidural and they were not feeling an urge to push. They would wait a maximum of 2 hours and then they would start pushing. In this alternative group, when they were ready to begin pushing efforts, the hospital staff assisted them into a specific side-lying position. In this position, the lower leg remained extended on the bed and the upper leg rested flexed on a stirrup. This placed the foot of the upper leg in a higher position than the knee to allow the upper hip to rotate. The birthing person's upper body was placed in a neutral position and supported with pillows if necessary. So when the researchers compared these two groups, they found that those who delayed pushing and gave birth in a side-lying position were less likely to need forceps, vacuum, or fundal pressure. Fundal pressure is kind of an outdated technique that's still used in some countries where they push on the top of your uterus from outside of your abdomen while you're giving birth. So the people who were in the alternative group had forceps, vacuum, or fundal pressure only 20% of the time, and that was more than doubled in the traditional group, which had vacuum, forceps, or fundal pressure 42% of the time. Also, 40% of the alternative group gave birth with an intact perineum, meaning they had no tears or episiotomies, compared to only 12% in the traditional group. There was no difference between groups in the rate of first, second, or third degree tears. So the reason that the intact perineum rates were so much higher in the alternative group was really because they had a substantially lower rate of episiotomy. The side-lying or alternative group had a 21% rate of episiotomy compared to 51% in the traditional group. So that was one study demonstrating the harms of the lithotomy position during pushing. The second study on this topic also took place in Spain, and in this study they were looking specifically at people with epidurals as well, and they randomly assigned 150 patients to position changes every 5 to 30 minutes in the passive phase of the second stage of labor, or to being instructed to lie down for the entire second stage. Both groups were instructed to delay pushing until they felt a strong urge to push, and unfortunately, everyone was instructed to get in the lithotomy position for the delivery. So this study is really looking more at the time period leading up to the delivery, during the passive or waiting phase. So they found that the people who did position changes during the passive phase of the second stage had better outcomes than the group that was lying down for the entire second stage, even though everyone eventually gave birth in the same lithotomy position. But the group that did change positions during the passive phase had fewer cesareans, 1% versus 10%, fewer cases of having vacuum or forceps used on them, 24% versus 39%. They also had a substantially shorter second stage of labor by about 30 minutes and fewer episiotomies by half. So looking at these two studies on epidurals and the lithotomy position, basically the evidence that we have continues to show that the lithotomy position is harmful and should not be used for the pushing phase or even the passive phase, and especially not the delivery in people with epidurals. And of course, in people who are giving birth without an epidural, it's very unlikely that they would naturally choose to get into the lithotomy position unless they were instructed to do so. And we can probably apply some of these results to those people as well and say that the lithotomy position is just basically harmful for everyone. And researchers have been saying that for a really long time. There's another section in the updated paper I'm not going to go into detail about, but we do have a section of this paper called the evidence on birth seats or birth stools. And this evidence applies to people with and without epidurals. And this section is mostly unchanged, but I just wanted to point out a fun quote that I was able to add to the beginning of this article, and that is that birth seats or stools have been used for thousands of years. For example, they are mentioned in the book of Exodus, Chapter 1, verse 16, when you serve as midwife to the Hebrew women and see them on the birth stool. I added that quote because I think it's interesting to show that for thousands of years, midwives have been assisting people on birth seats or birth stools. And you can go to the article to read more about the encouraging evidence on birth seats and birth stools. We also link to a video from Evidence-Based Birth where I talk about the different types of birthing stools and show you some examples. So you can go to the article to find that video. Next, I want to talk about positions that can be used during pushing versus actual delivery. And you might have heard me refer to this when I was talking, for example, about the lithotomy position and how the researchers sometimes, with research on birthing positions, they'll, quote, let you or encourage you to push or to lie in different positions or get into different positions while you're waiting for the delivery. But then when it comes to the actual birth of the baby's head, shoulders, and body, they have you get back into the, quote, traditional delivery position on your back. So in my discussions with professionals and parents around the world, I hear this over and over, that some providers may be willing to support pushing in an upright position, either in the passive or active second stage. But few obstetricians will attend an actual birth or delivery in an upright position. For example, healthcare workers may be supporting someone as they push in a squatting position, but right before the baby emerges, they may insist that you sit back in a semi-sitting or lying back position for the delivery. The staff may say something like, I need you to get onto your back right now for safety reasons, or you don't want to tear, do you? Then get on your back right now. Or, this is my favorite, your baby is going to get stuck under your pubic bone unless you move on your back right now. In other words, it's common to be given a vague threat combined with an urgent direction. This can be really confusing for parents because they may get the impression that it's a true emergency, which is a possibility, of course. There's always emergencies that can happen during birth. So parents almost always comply with the instructions to get on their back. But many times it is not an emergency. It's just that the healthcare workers are using an urgent tone and they're having language about vague threats. But there's nothing wrong with the birth or with the baby. So the coercion that some providers use to get patients to lay on their back may be due to a general anxiety and fear that they have about upright birth. Since most healthcare workers are not trained in true upright births and deliveries and rarely, if ever, see one, an upright birth might make a healthcare worker feel nervous and uncomfortable. And the easiest way for them to relieve their own feelings of anxiety is to pressure the patient to lay on their back. The desire for some medical staff to have the delivery happen in a more, quote, controlled manner, aka a non-upright position, is so strong that many people have shared stories with us of being coerced or forcibly put into non-upright positions during childbirth. And this can be very traumatic for a doula or birth worker to witness as well as nurses who know that this is wrong. So in our signature article on this topic, we state clearly that it is best practice for hospitals, obstetric providers, and nurses to support birthing people in their right to choose positions for pushing and delivery. This does not mean that providers cannot encourage different positions or frequent switching of positions if they feel it would be helpful, but it is unethical for a provider to use coercion or force to achieve a delivery position, and we underlined that in the latest update of this article. I'd also encourage you to go back and listen to EBB Podcast, episode 225, with Mandy Irby, the birth nurse, about how the lithotomy position could be considered an unethical restraint. There's a section in the paper about practice guidelines on birthing positions, and largely the professional organizations around the world recommend that birth attendants are trained in upright birth and that they support the birthing person's right to choose their pushing and delivery position. I love the recommendations from the Royal College of Midwives in the United Kingdom. They recommend the use of active and upright positions to assist with labor and delivery, and they urge providers to be proactive in demonstrating and encouraging different positions in labor, since birthing people often choose to do what is expected of them, and since the most common image of labor is on the bed and giving birth on your back, many people may choose to labor and birth on their back, and they might need some encouragement or demonstration or posters on the wall or education on how to birth, labor, and deliver in upright positions. The Royal College of Midwives also talks about how the environment is key to freedom of movement, and they suggest that we have a variety of furniture and props in the room to encourage people to try different positions, such as bean bags, mattresses on the floor, chairs, and birth balls. And they recommend that midwives support clients by giving suggestions on how to remain upright, even if you're in a situation that might limit mobility, such as with continuous electronic fetal monitoring, IV fluids, and different pain medications that are being used for pain relief. Now I'd like to summarize the benefits and risks of upright birthing positions for you. Overall, evidence from randomized trials suggests that if you do not have an epidural during labor, upright positions during the second stage provide several benefits: a lower risk of the fetus having abnormal heart rate patterns, less pain, and lower use of vacuum, forceps, and episiotomy. Upright birthing positions may also shorten the second stage of labor and lessen the chance that you'll need synthetic oxytocin or Pitocin to help you during the second stage. In terms of risks of upright birthing positions, some studies have found an increase in second-degree tears with upright birthing positions, but this risk is considered a good trade-off in exchange for a lower rate of episiotomies. Also, it's possible to reduce the rate of tears even more by using the evidence-based hands-off method in the second stage of labor, which we cover in the Protecting the Perineum series of the Evidence-Based Birth podcast. The evidence on birthing positions for people with epidurals is less conclusive. So far, researchers have not identified clear benefits or risks of upright positions. But researchers have consistently found that the lithotomy position has many harms, and this is the case even if you have an epidural. The bottom line, though, is that people giving birth have the right to push and give birth or deliver in whatever position is most comfortable for them. Both evidence and ethical guidelines support this bottom line. In the United States, both ACOG and the American Nurses Association have issued statements affirming the importance of patient autonomy. Personal autonomy is defined as the belief that all people have inherent worth and dignity, and thus the capacity for self-determination, for self-governance, and freedom of choice. The Code of Ethics for Nurses recognizes specific patient rights, especially the right to self-determination. The Code of Ethics also holds that nurses have an obligation to preserve, protect, and support the moral and legal rights of patients. It is an ethical violation for care providers to restrict someone's freedom of movement or coerce someone into a specific labor or delivery position. This is especially true if you're having an unmedicated birth and you're feeling everything, because movement and positioning are proven pain management strategies that could make the difference between coping versus suffering. But how do we put this bottom line into practice? I have suggestions for educational programs, physicians, midwives, nurses, doulas, and families. And in particular, the action statements for nurses, childbirth education, and parents are new. Given the evidence and ethical guidelines, educational programs should begin training all students and residents on how to support deliveries in a variety of birthing positions and teach about the harms of the lying back and the lithotomy positions. Our future healthcare workforce must be equipped to uphold the ethical and evidence-based standards of their profession. Physicians and midwives should strongly advocate for birth environments that support patient choice in birthing positions. If physicians are listening and you feel that your training and experience have left you anxious about managing complications at an upright birth, you should reach out to midwifery colleagues about training and support on this matter, as many midwives, although not all, are experienced and confident with the concept of an upright birth. New action statement for nurses. Nurses should seek training and mentorship in upright birthing positions and encourage their patients to push and deliver in upright or sideline positions. Nurses can physically assist patients into a variety of positions using all the props and tools available. They could ask their patient, "What position would you like to be in when the baby comes out?" Then let the provider know the patient's preferred delivery position. Nurses can also advocate for upright birth to be taught to patients in hospital childbirth education classes. Doulas and childbirth educators, and we have new action statements for childbirth educators, can nurture a supportive environment for birthing people to have the delivery position of their choice. They can physically rehearse different positions with their clients, and we do this in the EBB childbirth class. They can role play what the patient can do if they experience pressure to get back into a back-lying position. Again, we do that in the EBB childbirth class, but I encourage other childbirth educators to do the same. And most importantly, teach advocacy skills. Doulas can support their clients' wishes by asking them right before the delivery or pushing phase to remind everyone what position the client prefers for the delivery. So you could say something like, Remind us again what position you want to give birth to your baby in. And then after the client answers, the doula could say out loud in front of the healthcare team, all right, it sounds like you want to give birth on your hands and knees. That's great. We're all on a team to support you and honor your wishes. Finally, new action items for expecting parents. Birthing people and their partners should be upfront and honest with their healthcare team about their birth plan. During a prenatal visit, have an open discussion with your healthcare provider about your preferred positions for pushing and the delivery. If your healthcare provider and their practice partners do not seem 100% supportive with the concept of an upright birth, consider switching providers if that's something you're able to do. In fact, we have had countless parents from the EBB childbirth class switch providers after learning about the evidence and learning about whether or not their provider will truly support their wishes for an upright birth. So you can visit some of our EBB episodes that give inspiring stories of how parents switch providers, which can seem daunting and seem like a difficult thing to do, but our childbirth class graduates have done it a lot. And I'll give you a couple episodes that I'll link to in the show notes, but episodes 127, 186, 208, 223, and 231 are just a handful of stories of parents who switched providers, and we'll link to those in the show notes. And finally, if you are unable to switch providers or you end up with a provider who is not supportive of your wishes, ensure that you have an advocate or two by your side who can speak up and reaffirm your human right to give birth in the position of your choice. And that's it for this episode about the updated evidence on birthing positions. Thank you for joining me and talking about this research update. Don't forget to go to the signature article itself at ebbirth.com/birthing positions. That's all one word /birthing positions. And we have a whole bunch of resources that we list there to different podcast episodes. We also have a one-page handout that you can download to help facilitate conversations with your clients or providers. And while you're on our website, if you're listening to this episode before the webinar comes out, make sure you sign up for our free webinar on Pitocin at ebbirth.com/webinar. I hope to see you all there. Thanks, everyone. See you next week. Bye. Today's podcast was brought to you by the signature articles at Evidence-Based Birth. Did you know that we have more than 20 peer-reviewed articles summarizing the evidence on childbirth topics available for free at evidencebasedbirth.com? It takes 6 to 9 months on average for our research team to write an article from start to finish, and we then make those articles freely available to the public on our blog. Check out our topics ranging from advanced maternal age to circumcision, due dates, big babies, Pitocin, vitamin K, and more. Our mission is to get research evidence on childbirth into the hands of families and communities around the world. Just go to evidencebasedbirth.com, click on blog, and click on the filter to look at just the EBB signature articles.